This table shows abnormal respiratory patterns, such as Cheyenne-Stokes. We're going to look at, this is a key indicator. I'm sure there's 2, maybe 3 test questions buried in this. All right, so Cheyenne-Stokes respirations. What do I remember from Cheyenne-Stokes? Don't remember a lot. Kussmaul. Kussmaul is for diabetic ketoacidosis. Let's see what Cheyenne-Stokes is. So this is Cheyenne-Stokes, right? As time goes on, we have increased respiratory and decrease, and it goes in this pattern of increasing, going down, going up, going down. So gradually increasing rate and depth of respirations, followed by gradual decrease of respirations with intermittent periods of apnea. Here, nothing's, or very minimal breathing is happening. Associated with a brainstem insult. So this is when something is messing with the central nervous system. And I want to say intracranial, this is part of Beck's triad, but I don't know that for sure. That was on the test. There was Beck's triad, there was Cushing's, could be Cushing's, and there's a third one, I can't remember. Kussmaul respirations, deep, rapid respirations. All right, deep, rapid respirations. What are we trying to do? We're trying to get rid of CO2. Why? Because there's too much acidity that is in the body. So we're trying to get rid of it because of metabolic acidosis. But our goal is to get more alkali. So let's see what this says. Deep, rapid respiration seen in patients with diabetic ketoacidosis. I guess that's as much as it goes into it right now. But if you're in diabetic ketoacidosis, so think about what's happening to you. You're hyperglycemic, DKA. There is too much glucose in your blood sugar, and your cells, you're metabolizing more acid is being produced, making the blood more acidic. Ataxic, biot. Irregular pattern, rate, depth of breathing with intermittent periods of apnea. So this results from intracranial pressure. What happens to get intracranial pressure? We had a patient last night that fell and had a giant goose egg on her head. And her blood pressure was like 183/76, something like that, pretty high up there. So pretty sure she had some ICP. It wasn't maxed out, but it was on its way as far as increasing. So you could have an irregular pattern in rate and depth of breathing with intermittent periods of apnea. Ataxic. Taxic, that's a word. Okay, here we go. This is a Greek word. Taxic, like epitaxis. Taxis is arrangement of something, an arrangement. So now there's not an arrangement. Ataxic, the opposite of arrangement. What would that be? Irregular pattern. Boom. That is why you want to know your Greek words and origins. Apneustic. Okay, just like ataxic. Apneustic. Ap, the opposite of pneustic. What is pneust? Pneustic? Breathing? No, pneustic. Okay, this one. Pneustic is fluid in a vessel. Fluid in a vessel. So now there's not fluid in a vessel. So let's see what it says. Prolonged gasping inhalation followed by extremely short ineffective exhalation associated with brainstem insults. Prolonged gasping. So you're gasping pretty long, followed by extremely short, ineffective exhalation. That was kind of hard to follow. Agonal. Okay, this is happening at the end of someone's life if they have been in cardiac arrest long enough, and I'm sure other things can happen as well, but also known as guppy breathing, where it's like the body, the brain is sending signals to the lungs, to the diaphragm to breathe or to stimulate breathing, even though the heart is arrested, which is kind of mind-blowing because, you think the heart's the motor that pumps blood for the body to do other things. But now it's going from the brain, telling the body, hey, keep breathing, and it is the last thing that is happening right now. Agonal gasps. Slow, shallow, irregular, or occasional gasping breaths result from cerebral anoxemia. not sure what noxia is. That's probably another word that'd be interesting to look at. Agonal gasps may be seen when the heart has stopped, but the brain continues to send signals to the muscles of respirations. There you go. All right, so auscultation breath sounds with stethoscope. This is where we are going to auscultate. Auscultate means listen. So we go to the second intercostal right here. If we're looking for our intercostals, this is our clavicular muscle right here. So if we feel our clavicle, right, this is our clavicle, and we go down a little bit, there's that muscle there. But if we go a little further, okay, there's an intercostal space. This space right here, it's a pretty big one. We don't want that one. We want to go one below it. Feel it. It's kind of hard to feel where the pec muscle is, so you want to go as close to the sternum as possible. Yeah, you don't want to go to the armpit. So that's going to be our second intercostal space. We keep going down. We want fifth intercostal space. Another way to, well, also you want to drop it a little bit lower, third intercostal space as well. And you'll do the same on the back. But if we're listening to the lower one, this is our next landmark. So fifth intercostal space, if you stick your hand on your armpit where your pinky's at, is typically going to be your fifth intercostal space, which is also where we would needle decompress somebody if they had a tension pneumothorax, if there was air in that sac around the lungs, and we got to get rid of that air so the lung can fill up with air, not the sac, the lung that needs the air. We're going to go to that fifth intercostal space with I forget what the gauge of the needle is. I want to say it's 2.25 long, and we stick it in there so that way the air can rush out. And now the air can breathe into the lung to inflate it. And if it stops and we still have tension pneumo, we're going to go right next to it with another one. Don't hit the rib. We want to hit the intercostal space. Breath sounds that are created as air moves through the tracheobronchial tree. Tracheal? All right, trachea here. Bronchioles go down, split at the carina. Tracheobronchial tree. Which word means tree? I think it's ino, or no, that means root. Inotropic root. Size of the airway determines type of sound. Breath sounds heard over majority of the chest represent airflow into the alveoli. Tracheal breath sounds, bronchial breath sounds heard by placing the stethoscope on the diaphragm over the trachea or the sternum. Assess during pitch, intensity, and duration. Vesicular breath sounds, softer, muffled sounds. Expiratory phase, barely audible. Bronchiovesicular sounds, so vesicles are on like the outside of the lungs. These are the vesicles like over here towards the lung, all the way down. Heard in places where the airway and the alveoli are found. Should be assessed for duration, pitch, and intensity. So if we look at our chart, the thicker that this line is, that is the stronger of the breath. And then as it's going up, that's our inspiration. Held it for a little bit, now it goes down. But this is all a heavy breath sound. Here it's less inspiration, but more expiration, but still heavy sounds. Here it's a little lighter, and then heavy long, elongated inspiration to light expiration. So this is tracheal if inspiratory and expiratory sounds are both loud. Bronchial if inspiratory sounds are shorter than the expiratory sounds, but they're still loud. Now we're going into the thinner parts of the lungs, further out here. So everything here, they're thick because this is thick. Lots of air can move down there, and lots of air can move here. In between here, it is harder to move air around, so you're going to hear less sounds. Bronchiovesicular, inspiratory and expiratory sounds are about the same and medium intensity. So almost the same. Bronchiovesicular, kind of in the middle. But now we're out towards the edge. Vesicular, inspiratory sounds last longer than expiratory sounds, but both are, in fact, faint. Duration, length of time for inspiratory and expiratory phases of breath. Normally, expiration is twice as long as inspiration. 2-to-1 ratio. Inspiratory, expiratory, i.e. ratio. When the lower airway is obstructed, the lower portion of your lungs, expiratory phase may be 4 to 5 times as long as inspiration. IE ratio 1:4 or even 1:5. In patients who are tachypnic, tachy, fast, tachypnic, the expiratory phase is short and approaches that of inspiration. Could be 1-to-1, just like that. Pitch is described as higher or lower than normal in stridor and wheezing. Intensity of sounds depend on the airflow rate, constancy of the flow through the inspiration. Patient positioning matters as well. Patient site elected for auscultation, and less intense sounds are said to be diminished. Always auscultate directly on the skin. We don't want to go through the shirt. Sounds that are present in an unexpected area can indicate abnormal position. Dude yesterday had a metastasized mass in his lung. He also had it in his brain as well. Adventitious, abnormal breath sounds, usually classified as continuous or discontinuous. You have wheezing. Continuous sounds is airflow through the constricted or lower airway, and then high-pitched, a sound that may be heard on the inspiration, expiratory, or even both. Bronchi, continuous, low-pitched sounds. All right, so we're in the upper airway. This is our wheezing. This is asthma. This is even stridor. Did I say stridor? Stridor, if it's a toy. If it's a child, you probably swallowed a toy. You'll hear high-pitched wheezing. Bronchi is lower. It's more into the lung. Continuous low-pitched sound. I should have this camera angled at me. I just keep doing this and can't even see. Continuous low-pitched sound indicate mucus or fluid in the larger lower airways. What does water want to naturally do, right? Gravity pulls it down. So we're in the lower part of the lungs, bronchi. Crackles, formerly known as rales, crackles and rales. Bronchi, I always get mixed up with rales and bronchi, but crackles and rales occur when airflow causes mucus or fluid in the airways to move into the smaller lower airways. So bronchi is just heavy in the big portions, but if that fluid moves to the vesicular, to the outside of the lungs, through the bronchial branches deep into it, you're going to get some crackles. It occurs when the airflow, just said that, tend to clear with coughing. So it takes, because there's a little mucus, little fluid, you can clear it with just a little effort, just a cough, right? It'll be easier to clear out. May also be heard when collapsed airways where alveoli pop open. Classified as discontinuous sounds, may occur early or late in the inspiratory cycle. Early inspiratory crackles usually occur whenever there's larger proximal bronchi open. Common patients with COPD tend to clear with coughing. Late inspiratory crackles occur when peripheral alveoli and airways open up, more common in dependent lung regions. I don't know what a dependent lung region is. Stridor. So here we go. This is just like wheezing at the top. Results in a foreign body aspiration, infection, swelling, disease. Could be croup as well. That's a disease. Trauma within immediately above the glottic opening, above the epiglottis where we would intubate. Produces a high-pitched sound, typically heard during inspiration. A pleural friction rub results from the inflammation that is caused from the pleura to thicken. Pleural is that lining between the skin and the lung, and there's several layers there. But there's pleural is whenever it rubs together. It's painful, I believe. Surfaces of the visceral and parietal pleura rub together. Parietal, these words are kind of the same, but not completely. Visceral is more like invisceration, visceral on the outside. Parietal is around it, I believe, is the difference. Often creates stabbing pain when breathing or any movement of the thorax. There you go, very painful. Quantifying ventilation and oxygenation. Let's stop there.